Hello, everyone. Welcome to the fourth webinar. And this one's on exploring an extended role in lifestyle medicine. And we're delighted that there's been quite an uptake. Welcome and welcome to Sally and Hussein, who are joining me today in delivering this webinar. Just start with a bit of housekeeping and a welcome. We've basically got about a 40-minute presentation. It's going to be quite informal. We know that you've probably been at work, you might be knackered, you're cooking dinner, or if you're like me, you might even be driving home from work. Please do just engage in the chat or the Q&A. The chat function is disabled, but the Q&A isn't. So put questions in the Q&A. We'll pick them up as we go. And if there's any questions we haven't answered, then we will provide written feedback after the event. We often get asked, are the slides going to be available afterwards? And they will be. In fact, the whole thing's being recorded and it'll be available on the RCGP YouTube channel at the end. And finally, there is a post-webinar evaluation. We'd really appreciate if you could fill it in, and hopefully we can kind of take those learnings and make the last two even better. So for those that haven't been in the previous webinars, I'm Callum Lees. I'm a GP up in Scotland, although today I'm zoomed in from Utrecht in the Netherlands. I'm an academic fellow at the University of Dundee, and along with Hussein, I'm one of the champions for physical activity and lifestyle at the RCGP. Hussein, do you mind introducing yourself?
Absolutely. Thank you, Callum. My name's Hussein, a GP based in the West Midlands. Alongside Callum, one of the physical activity and lifestyle champions at the college. Also have a portfolio career. Two kind of key roles is working with park runners, their health partnerships lead, as well as Swim England as one of the advisors on the Health Commission.
Great, thanks, Hussein. And Sally, do you mind introducing yourself?
Absolutely. Hi, everyone. I'm Sally. I am a GP of 25 years, coming to you from my consulting room in central Derby. So I've got an interest in lifestyle medicine. I've been doing a GP fellowship in lifestyle medicine for the last year and set up and run GP lifestyle medicine clinics for small numbers of patients. I'm also the East Midlands lead for the British Society of Lifestyle Medicine.
It was great to have you.
Thank you.
I always start my slides now with a bit of a disclaimer. I'm a pathological enthusiast. I'm also, I know that Hussein is too, and I'm pretty sure that given your resume, Sally, that you are as well. And I'm aware that I'm very much an early career GP, and I try and make up for my lack of experience with enthusiasm. But as well as questions in the Q&A, we just love feedback. So hopefully it can be as interactive as possible, because there's probably things that you're doing that we could learn from. And so, yeah, please do contribute anytime. What's the purpose of the webinar? Basically, to outline the GP with extended role in lifestyle medicine. Firstly, explore the purpose of the framework, the core elements, requirements, qualifications, which is often the biggest part. At least that's the most questions we usually get. And then finally, implementation and how we use it. First of all, I suppose defining lifestyle medicine is important. And maybe I put both Sally and Hussein on the spot here and ask you, Sally, what does lifestyle medicine mean to you?
So lifestyle medicine, a global medical speciality that is evidence-based, that helps patients reduce their risk and potentially reverse their risk of chronic disease, which comes along supported behaviour change models that you can use with patients, which is what we've been doing in clinics. So that's what lifestyle medicine means to me.
Almost like you read the slide, but Hussein, how about you? Anything else you want to add?
Yeah, the nature of disease that we're seeing and the health burden in our population has changed dramatically. Historically, acute illnesses, particularly infectious diseases, dominated the medical landscape, and now as we've already touched on, this has led to kind of ill health and a serious rise in long-term conditions. And given the connection between lifestyle behaviors and long-term conditions, there is a compelling need to reconsider our approach to medicine and understand its context alongside the social determinants, appreciating that those in society, there is an unequal level of support and opportunity to lead a healthy life, as a lot of the work that, for example, Sir Michael Marmot has published.
Yeah, great. Thanks for touching on the social determinants part, which we will, about 2 slides on, we will cover. So yeah, that's a forewarning. So what's the purpose of the framework for a GP with extended role in lifestyle medicine? The framework actually has been around for just over a year now. And Hussein was part of the team which created it. And so Hussein, when you set about creating the framework, what was the purpose in doing so?
Yes. So chief amongst the reasons behind its creation was a demand. When clinicians, GPs were surveyed as to what they wanted to support in terms of having a framework on which extended role they would like that in, lifestyle medicine came really high at the top there. And the framework was designed to give some direction, as well as give a kind of indication as to what the scope of lifestyle medicine within primary care is, what it can look like, and what training is required and ongoing maintenance of CPD that is needed in order to work in this space. So just like the other extended roles that we have, for example, in frailty, women's health, etc., it's really important that if we are going to deliver lifestyle medicine appropriately, that it needs to have the same rigor and sort of framework in place. I'm really glad that that was done, and already I can see the benefits that it's brought about by having that structure.
Right. I think you've summarized that slide really well. So thank you. There's 3 core elements to the framework for GP with extended role in lifestyle medicine, and they're the same core elements to lifestyle medicine itself, which are understanding of the social economic determinants of health and health inequity. And I think importantly, in lifestyle medicine, that comes first. That's the basis on which everything else is built. The second is training or knowledge of lifestyle changes, and particularly behaviour change. And then the third, and the one that you've probably heard about, is the 6 pillars of lifestyle medicine. Regarding the social economic determinants of health, I really love this slide because I think it kind of outlines the determinants of health holistically, and also where lifestyle medicine works, where medication and surgery work on the right, and then where government, local councils, town planners work, which is much more upstream. And Hussein talks a bit about this, and kind of the god of this really is Sir Michael Marmot, and his book The Health Gap is absolutely worth a read. Sally and Hussein, this is possibly a kind of slightly unfair and difficult question, but I did forewarn you. But would you be willing to talk about some of the determinants of health in your communities? Sally, I know you work in Derby, and maybe you can start and then hand over to Hussein.
Thanks, Callum. So yes, we are placed right in the middle of Derby. So we are a city centre practice and have all the health issues that are associated with living in the city centre. In general terms, we have around 200% of the mental health percentage compared to the rest of the country on average. We have high drug usage, high drug populations. We have populations that have a significant percentage of obesity, very deprived ward that we work in. I think Abbey ward that we work in is one of the top deprived wards in the country. So lots of upstream socioeconomic determinants within the city centre.
Yeah, no, just to,
yeah.
Oh, sorry. Yeah, so just jump on that. Like in my area in Leamington, we see real differences just in the space of 500 meters, maybe a kilometer, in terms of the kind of communities that form. North Leamington is quite affluent. It has very good health outcomes when we compare it across the West Midlands. But then when you look at South Leamington, in particular areas like Sydenham, Radford, Semley, we see the opposite. These are pockets of severe deprivation. There are lower educational attainment, lower employment. We see poorer housing conditions. Unfortunately, in those areas, we see a high representation from various different ethnic groups, in particular South Asian, as well as Eastern European. And what we see in terms of outcomes, they are the dominant makeup when it comes to our long-term conditions and the key ones that we try to support and address. And so when we are delivering the kind of lifestyle medicine projects that we do at the Lamington Primary Care Network, we really target these groups, because that is by far and away how you go about trying to bring equity into that, by sort of basically over-representing them in the various projects that you're trying to use. Because if we just kept it open, and we do have self-referral, you know, patients can go on the practice website and sign up to our services at the lifestyle clinic. But then when you look at who are signing up, it's nearly all North Leamington. So they're the ones that have got the activation to access the kind of groups that we run. In order to access the other group, which often the term hard to reach is given, is instead like, how do we proactively pull them in? So we send batch text messages, we do cold calls with our health and wellbeing coaches and social prescribers to encourage them into the groups. Because interestingly, once you get them in the group, in terms of actual outcomes and improvements, you do better with you know, the group from the deprived areas. Actually, you see more health benefits coming through. The key is, how do you get them engaged and at your services?
Yeah, I think that's a really key point, and pertinent to probably everyone on the call is how do we engage the people that need it most. I'm probably in a slightly different community. I'm in rural Scotland, and as well as many of the barriers that you guys have mentioned, you both have mentioned, there's a few, but one particular that really kind of hit home recently is that our only shop or only grocery store was a co-op for probably about an hour. And when they had a kind of hacking crisis, and there was no fresh fruit or veg on the shelves, and so and not only that, a co-op's quite expensive. So you realise that you know, in rural areas, that those kind of economic determinants of health can be slightly different to those in more urban areas. I'm aware there's been some questions in the Q&A, and Luke, thanks so much for them. Keep them coming. A lot of them I've flicked through, and I think we'll cover quite a few of them as we go through the remainder of the presentation. If not, we'll come back and address them afterwards. I know there's been a question about courses. We're not in a position to really comment specifically on or advocate for any particular courses, but we do cover that, so we'll hold our breath and get there. The second core part of lifestyle medicine and the framework is skills to support behaviour change. Sally, you've got an amazing bio. I've got one slide to you. You've got an amazing bio, and I would love if you could tell us about some of the behaviour change skills that you utilise and how you came about to acquire them.
Thank you, Callum. So yes, I became interested in the coaching approach to lifestyle medicine. I'd done the dual international and British diploma of lifestyle medicine back in 2022 and wanted to utilise that. And then looking at developing this lifestyle medicine clinic that I've been doing over the last year, it became very clear to have some coaching skills would be of benefit. We are able to refer on to Derby County Community Trust, who do have some coaches and wellbeing tools. But because I was seeing my patients in my surgery, I also wanted to be able to offer some of that. So when my first opening gambit really in terms of coaching is when they come to clinics, my first question to them will be, what is your why? Why are you here? Just trying to generate some thought processes or try to clarify where they are in their journey. So I went to help facilitate all of this. I then did a diploma in coaching, which has just come to the end with your coaching journey, which was incredibly helpful. And it has been really lovely seeing how patients have reacted to a slightly more coaching approach. So you are working with them as an active partner. They're not having something done to them. They're not having a medical intervention. They are working with you as a partner. So so that would be my opening question, and then from a coaching approach, lots of active listening at that point, with a very person-centered approach if we're looking at how we'd work this in terms of coaching. And then when we've decided where we might be going in terms of goals, we then might swap to a more structured approach and look at some SMART goals, and a behaviour change approach. So I've got lots of questions that I would usually discuss with patients. And one of the ones that I found is most powerful is, how will you know when it's the right time to make a change? So patients will love that. They'll think about that. And the answer may be, well, actually, I want to do something tomorrow. Or they may not be quite at that stage. If you're looking at a trans-theoretical model of behaviour change, they might think, I want to do that maybe in a month's time. I might want to buy a pair of trainers first, or, you know, there may be some little barriers. I would ask them, in terms of a coaching and behaviour change approach, what success would look like for them. So we're both working together, knowing where we would be aiming for. I'd want to know what they'd already tried. I'd want to know what's getting in their way, what kind of barriers they may have, and then try and cut that down into smaller chunks and allow them to take baby steps with support from myself. You will also come across quite a lot of cognitive distortions and patients believing they can't do something because this has happened in the past. So there's also the opportunity to do some cognitive coaching in that and look at discrepancies in thought processes there. So the coaching approach and behaviour change is really crucial to lifestyle medicine approach in the clinics. So those are the kind of basics. In a booklet that I've actually produced for my patients, there is a set of coaching questions in there, so they can actually work through those coaching questions. And I do get them to write down what their why is, so we can keep referring back to that as well.
Well, thanks, Sally. So a couple of key questions. How will you know when you're ready to make a change, and what will success look like? One of the questions that I'm sure that will come up is, you know, if I'm a trainee, or if I want to do a bit more, but a diploma sounds like a lot of work, then what can I do? We will answer that later. Another thing that jumps to my mind is time. You know, it sounds amazing and holistic, but how do we have the time? And one of the things that I'll maybe point out, and you can add to this, is that this doesn't all have to be done in one consultation. You know, we have the joy of continuity of care in primary care, and so although you've answered that succinctly for such a broad topic, it might take weeks, months, or even longer. Great. The third core part of the framework is the 6 pillars of lifestyle medicine: mental well-being, healthy relationships, physical activity, healthy eating, sleep, and minimizing harmful substances. We will go through all these individually just a bit shortly, as we outline some of the stuff that's in the framework on the RCGP website. But again, I wanted to reiterate that this comes as the third point in the framework, after the social economic determinants of health and the need for the techniques and the skills in which to deliver them. So this slide's wordy, but this is a fairly key slide. If you're going to stop and pause your cooking your dinner for just a few seconds, then this is a slide to pause on, because this is the kind of 6 key points of the framework that's worth documenting evidence for, to prove or to try and become a GP with extended role in lifestyle medicine. And these are the things that you might present at your appraisal to prove that you are a GP with extended role in lifestyle medicine. So those 6 things: the first, comprehensive and holistic assessment of the 6 pillars, whilst accounting for social economic determinants of health. Using a whole person biopsychosocial approach, multidisciplinary team working, and hopefully Sally and Hussein will be able to outline kind of the teams in which they work later. The use of group care, I don't think this is compulsory, but this is worth something considering, and I know something that Hussein has definitely done and led on. So group consultations, groups, clinics, shared medical appointments. Careful review of medication, including down titration and deprescribing. And then finally, mentoring of the lifestyle medicine MDT. What other roles are you supporting as you head up a multidisciplinary team in lifestyle? So coming back to those 6 pillars, we'll go through each one individually. The first, mental well-being. Sally, what skills are important for assessing mental well-being, and do you have any tools that you use in particular? I know you mentioned earlier about having a booklet.
So the mental well-being, when I've seen patients specifically in lifestyle medicine clinic, we do go through each of the 6 pillars. And for stress, mental well-being, I will come at that in my usual GP way, asking how patients are, if there's anything that's worrying them, are they particularly stressed, how their mental health is. In terms of specific metrics for lifestyle medicine clinic and looking at whether there's been any improvements, I have actually used tools. I have used PHQ-9 scores for depression. I do use GAD-7s to look at patients' anxiety levels, because I wanted to see whether there was going to be physical improvements but also psychological improvements when you work on all 6 pillars in lifestyle medicine clinics. So patients are usually very happy to talk about how they are feeling and where they are with their mental health. I had 3 patients of lifestyle medicine clinics because their mental health was so bad at the time. So it's something that we're really well versed in talking to patients about, particularly the surgery. We have a lot of mental health issues. So I would use those 2 questionnaires specifically.
And Sally, would you send them out in advance? Would you get the patient to complete via an SMS, or would you do it in clinic with them face to face?
So at the very first appointment, and the very first appointment was an hour long, I used the then BSLM pro forma to ask about mental health, feelings, and we also used PHQ-9 and GAD score, and they completed that and brought that into the consultation with them. My follow-up appointments were shorter, they were about half an hour, and actually I did do that with them during that consultation, because it may bring up issues that you may wish to explore a little bit further at that point, and on occasions we definitely did. Occasionally I also forgot and then sent it electronically, and then they pinged it back to me. So that's how practically I did that within lifestyle medicine clinic.
Sally, for people that are listening, you talked about having an hour and 30 minutes with patients.
Yes.
For me, yeah. I'm kind of on 15 minutes appointments. That's the abnormal as opposed to the normal. Yes. How have you managed that? It's probably worth clarifying this for listeners.
Yeah. So to clarify, the way I've managed this is I've done funded lifestyle medicine clinics. I knew I wanted to set them up in Derby with a view to trying to expand on a PCN or an ICB level, but I knew that I'd need some metrics, some data, so I wanted to set up a clinic. At the same time as that thought process was going on, there was a fellow, so I applied for that, fortunate to get it. So I have been funded to do this, and it is just me doing it, and I'm sending out all the invites, I'm booking the appointments, I'm pretty much doing everything. But in terms of multidisciplinary teams, we've had a phenomenal set of PCN dietitians who I referred on to, and then at Derby County Community Trust Health and Wellbeing Service, who provide exercise programs for patients, along with other health and wellbeing projects. So I've been doing the doctory side of things, and then channeled patients off. So that's how it's funded. It is totally different in a 10/15 minute consultation, but that's where my booklet that I've produced for patients, if I've managed to get any conversation in within a 10 or 15 minutes, if you're interested in this, how would it be if I sent this to you? And then if they've got any questions, they can get back to me, because it is really hard in 10 minutes. Yeah.
And maybe we can share that booklet. So we'll put it in, if we can, we'll put it in the chat for
very
people
happy to. if that's
Thank
helpful.
you.
Yeah.
And without doing out of a job in the future, the fellowship, was it an NHS England funded fellowship? Will people be able to find it and if it's
It was
re-advertised?
funded by the educational arm of the LMC in Derby, so called the Hub Plus.
Quite
So
narrow.
I think it's specific to Derby,
Yeah,
and it was
yeah.
fortunate that it fell at the right time.
Yeah, thank you. Hussein, how about kind of relaxation methods? Have you got any favorite relaxation methods that you use with patients when you talk about mental well-being? I can't hear you, Hussein. I'm not sure if anyone else can. Still can't hear. Sally, can you hear Hussein?
No, I can't.
Okay. Well, that's all right. Sally, what can you take that question? Is that all right? I'm sorry.
Yes, that's absolutely fine.
Yeah, yeah.
So I will signpost patients to mindfulness apps. It entirely depends. I'd love to get my teeth into it, but it depends how much time we have got, because we are trying to do the 6 pillars at each consultation. So even within the half an hour follow-ups, I'll still be signposting patients. The Derby County Community Trust do projects and have group meetings where they will help patients with stress management, and not to forget the social prescribers, and particularly the social prescribing team that we're working with in Derby, absolutely fantastic. And they will help patients with stress management as well.
Yeah, I think that's a really interesting point, is just knowing what services are on offer in your local area, and then also having some more generic things you can offer. Apps, there's a world of apps, so have a couple that you maybe have been through and checked. Hussein, I'm gonna
Can
take
you
you
hear me
into
now?
healthy relationships. I can hear you now, which is
Yeah,
great.
excellent.
How would you bring up healthy relationships in a consultation?
Yeah. So really across the board in all the pillars, when it comes to actually how I kind of support patients in what that may look like in terms of the lifestyle prescription, whatever you want to call it, is I try not to ever generate the idea myself. Kind of what Sally's already mentioned in terms of the coaching. When I completed the coaching qualification, what it led me to understand is that when we give generic advice, it's like advice to the patient's ideas. When the patient comes and sees me, and maybe it's 10 minutes, 15 minutes, or even an hour in a group consult, I'll only ever see the tip of the iceberg. So if I think that I've got the ideas that are going to solve the problems that I don't even know half the answers for, then it's wrong. So I always ask the patient that you want. What is it that you're looking for? What matters most to you? And so what I then do is I just feed in the key bits of information to help them think about that. And I will often highlight the evidence around the importance of healthy relationships. And I'll get them to reflect on what maybe some toxic relationships and how that makes them feel, or what do good relationships, how that changes the mood, the sort of the health in general. And so when it comes to healthy relationships, some of the key questions that I ask is, for example, around, you know, I break it down into social connection, communication skills in terms of them expressing and having that kind of high quality relationship with others, and also boundaries. Because I think now more than ever, it's really important that people are aware of those boundaries and knowing when they're sort of essentially maybe crossing those boundaries, whether it be at work or in other relationships. So, like, key questions to ask about is, how do you feel about the relationships in your life in terms of sort of quality and quantity? Do you feel like you have a supportive network that you can lean on during difficult times? What does a good relationship look like, and how does that feel? And maybe then talk about the inverse of that. So yeah, like with the other pillars, it's about getting the patient to draw out their experiences and what outcome they want to look for in terms of that pillar.
Yeah, that's great.
Absolutely.
And I suppose the other thing that's really helpful is knowing your local resources. And there's so many great kind of warm cafes and different social things happening. I'm forever surprised uh, about what's happening in my community that I didn't know about, which is a really positive. Uh, okay, super. Thank you. If we move on to healthy eating, I think this is one of the big ones. I think this is often what people come in with questions about, and I find I spend time talking about healthy eating, nutrition. I've done group consultations and delivered a talk to diabetics, and the first question was, should I drink butter coffee? And you know, it was straight into the nutritional stuff and the stuff I was like, oh no, I know. So anyway, I think yeah, just highlighting that nutrition assessments, that's one of the things that's outlined within the framework. Yeah, Hussein first, maybe this time. Sally, I've put you on the spot quite a few times, but Hussein, what, if any, nutritional assessments do you use, and how do you go about bringing those into consultation, particularly if it's a short consultation, 10,
Yeah.
15 minutes?
Yeah. So in first of all, where I can and where the patient's engaged, I will encourage them to complete a food and mood diary. There are a number that you can download for free on the internet. And it also enables you to sort of bring them back for a follow-up. So I'll say, do you know what, like I can get a picture of kind of what you're eating at the moment, but I'd love to do a food diary. And that's useful because one, you get a more detailed image of what the patient's eating, but also the patient will often come back having reflected on it a lot more because for the first time they are noting down all the things they're eating, when they're eating it, what their mood is like in terms of their stress levels, etc. They're already starting to understand that food is far more complicated than calories, and there's so much more to it. And if I, for example, don't have a patient that maybe is engaged with that and I want to approach it, then I often ask them, I know, do you feel that you are eating a healthy and nutritious diet? I ask them what the view is, and I from 1 to 4, would they put it on? With 4 being, a really nutritious diet, 1 being less so. And so that is actually been shown in research that they can give you a decent understanding of kind of patients in terms of the and asking them, for example, how many vegetables they eat across a day and what kind of number that comes to just gives you another bit of indication of them thinking through. So, in a really time pressured consultation, keep it simple and try and utilize things like food diaries because it's amazing how much time the then patient thinks about what they're eating and why they're eating it. And when you come for that next follow up appointment, you get a lot more useful material to sort of delve in deeper.
Yeah, thanks, Hussein. I often use the question, "What did you have for dinner last night?" and then
Likewise.
follow up with, "Is that normal for you?" And I think that's a really nice way of bringing it up. Uh, there's a comment by someone called Emma in the chat, which I just wanted to highlight. I've been running a community cooking club at a local high school. It's been really interesting talking about how food opens up other pillars. Just wanted to bravo and yeah, please give us more details if you can. That sounds amazing.
Yes. Emma, on the RCGP Physical Activity Hub on that page, we have a place where you can submit case studies, like something like that. We'd love to hear about, and there's just a simple form that you can complete because it'd be great to showcase it and share it with others.
Sally, the second point here, give specific personalized advice about healthy dietary patterns of the patient's own choosing, is in the framework. I've got to admit, my knowledge and confidence of giving nutrition advice is growing, but it's always been pretty limited. I think medical school certainly didn't offer a huge amount regarding nutrition, and neither did postgraduate education. So a lot of that is self-learned. But yeah, I was wondering, is there just, if there's 1 or 2 things that you've done, whether it's a book or a course, anything you could recommend that's really helped empower you with nutrition knowledge?
I think most of my nutritional knowledge came from doing the diploma. And I'm aware of the limitations of my own nutritional knowledge. So I'd always be advocating a foundation diet. I ask the same, essentially do exactly the same as you can, saying in terms of trying to find out where someone is. Rather than asking patients how their diet is, I will often ask them how their nutrition is. So it might seem a little bit less threatening, ask them about what they'd had the night before. Again, look, if it's within a normal GP 10-minute consultation, I will fire off signposting information. As I mentioned, we've got great dietitians, so would signpost them there. But I would be talking about whole food nutrition, and by what do I mean by whole food? I mean food that you can look at and you know what it is. You are not peeling back plastic from a container and you actually have no idea what's in there. So trying to avoid ultra processed foods, lots of fruit, veg, to get some veg in is a really good start for some of our patients. You know, I know Zoe Project, etc., would suggest about 30 different vegetable products, nuts, seeds, berries per week. But I think you work from where your patient is and what you feel they can actually take on board in terms of sugar, salt, the basics, and then kind of grow off that.
That's great. And the diploma you mentioned is presumably the diploma of lifestyle medicine, which has been rebranded as the core accreditation. So, yeah.
So I'm not sure that it is essentially quite the same as the diploma that I did, but it's the qualification is now known as the core accreditation. Yes.
Thank you. Physical activity, very similar, starts with assessment of physical activity and personalized goal setting and support. Sally, you previously mentioned goal setting using the SMART goal framework. That's a pretty common one, which I suspect most people on the call know about because it's often mandated in our GP training. Hussein, I know this is a real passion of yours. How do you assess physical activity and sedentary time? And are there any other frameworks for goal setting beyond SMART goals that you could recommend or advise?
Yeah, no, great question. In terms of assessment in primary care, there's the GPAC, which kind of gives you a four different ratings from sort of highly active down to sort of inactive. Now, kind of the best way of assessing it again is just from understanding from the patient how asking that same question of asking them to rate how active do they feel, and we actually have a wheel where physical activity is one of the segments of the wheel, and we get them to sort of shade in how strong or weak they feel in that particular area, because I think what we try to do is to help them understand that movement is more than the exercises you do. And in fact, you can move a lot during your day, depending on the kind of work you're doing and what's happening. So we try to sort of get an understanding in terms of like in that brief time, the patient in front of you. I'll often just get them to give me that rating score of their kind of confidence and how much they feel they're able to move their bodies. And when it comes to goal setting, yeah, smart goals, like they've got good structure and it can be helpful, but it sometimes can feel a bit sort of business-like rather than personalized. So what I try to do as best as possible is to use a model that I got from a health coaching qualification, which helps them identify what the outcome looks like and what that may be. And then I break down with the patient what are the steps that will get us to that outcome and then apply the time-bound element to it. So I think what's really important is that you get the patient to structure what it looks like, and you're there to essentially guide and support and suggest from your expertise how they can go about.
Perfect, thank you. The GPAC, or the General Physical Activity Questionnaire, is an internationally recognised one. In Scotland, we've got our own one. We call it the Scott Pack. Public Health Scotland developed it, and they recommend that we use it. So yeah, if you are north of the border, then worth checking out, or even south of the border. Yeah, heaven forbid you might adopt it, but yeah. Super. Okay, great. There's a comment in the Q&A from Rachel Rooney just highlighting that I might have got my wires crossed, and apologies if I did. The International Diploma of Lifestyle Medicine still exists, but it's based in America, and the British Society of Lifestyle Medicine have their own core accreditation. So yes, they're both there, but there's kind of a change in the landscape, if that's fair to say. I can't remember what pillar we're on. I think this is number 5, minimizing harmful substances. The assessment of nicotine and alcohol, as well as caffeine, recreational drugs. I think in part, particularly nicotine, alcohol, and recreational drug consumption is often taught quite well in medical school. I think that's part of the routine social history that we do. And so I just wanted to pick out the second point, which was including gambling, technology, and social media. Sally, how often would you talk about gambling and or social media in a regular consultation?
It depends what we're discussing in the regular consultation and what the patients actually come with, and whether it may be something that's affecting their mental health. In a specifically lifestyle medicine consultation, the gambling question we would be asking every time, and perhaps at points later on if there were any things that were flagged up to begin with. Technology and social media addictions. Sometimes in normal consults, pornography will come up quite a bit, and patients' issues with addiction to pornography. So we'll refer on appropriately to mental health support and counselling. Social media, I think it depends on the context. If it is stopping them from, if that has become a harmful behaviour in terms of stopping them from doing something else, and they may be scrolling rather than getting out on a walk, as soon as they have acknowledged that or understand that, then we can look at that from a coaching perspective and see what we can do to try and change that habit.
Yeah, great, thank you. From a personal perspective, I'm more likely to talk about social media in younger people. That's probably a bias from my front, and often in a consultation about mental health. So,
I think with the
Hussein,
harmful substances, like a structure that you can use is, firstly, obviously, I find out if they, use or do the behavior, because obviously there's a behavior rather than substances for some of them. And then it's around finding out the frequency, finding out the impact. So, for example, with gambling, has it had an impact on finances, has it an impact on relationships, professional life, and then what attempts have they made to try to cut down on that behavior, and how's that made them feel. And so just trying to understand frequency, impact, and strategies or attempts that they've done in order to minimize it. That will give you a really kind of good idea in a very quick way.
Great, thank you. Sleep. Hussein, how do you assess sleep? If you were to assess it, how would you?
Yeah, so a lot of patients have trackers that they use and wearable tech that can kind of start that conversation. Because I find unless they are struggling with poor sleep, often patients won't bring this one up. But I think what we know now is that we need to look beyond just trying to correct insomnia and poor sleep that meets that criteria to actually how can we optimize sleep? Because there are a lot of health benefits in getting higher quality sleep. So I will look at the key sleep patterns. So asking about how many hours do they get on average? How easily do they get to sleep? So what's the onset like? How long does it normally take to do that? How well do you sleep in terms of is it interrupted? Does it feel restless? And are there any symptoms and signs of potential sleep disorders, things like obstructive sleep apnea? So I'll ask questions around that in particular where there are risk factors that are present. So yeah, trying to get an understanding and share that importance with the patient can be really helpful in terms of utilizing the sleep trackers. Actually, when you look at the data, by no means should we be relying on them as, medical grade assessment devices, but they can be helpful. It depends on the patient because some patients can get overly distressed and anxious with terms of the results. And at the end of the day, what we want to assess is what are the energy levels like? What are the symptoms like? And if they are feeling well and the tracker is telling them that they've got awful sleep, then maybe we shouldn't put too much weight onto it. So for some patients, it can be helpful to get them thinking and considering how they can optimize sleep. But for others, it can just lead to kind of increased anxiety and the negative outcome.
Super, thank you. I'm kind of aware of time and I want to be able to have time to answer all the questions, but these are the different roles that the framework proposes you could use your GP with an extended role in lifestyle medicine, moving far beyond just routine general practice into clinics, all the way through to policy settings, academia. Sally, briefly, if you can, what kind of roles have you managed to adopt, and in these different areas, how often or how many do you operate in?
So certainly using lifestyle, I'll just read through them. So certainly using lifestyle medicine at every given opportunity, just dipping little bits in there in normal consults. So definitely in routine general practice, Lifestyle medicine clinic services, yes. Healthcare leadership, not so much. Training and education, we've done a couple of talks recently sharing lifestyle medicine in Derby to GP registrars was the most recent talk we did. And there is a genuine interest in lifestyle medicine within the GP registrar community. I haven't ventured into secondary care or long-term prevention clinics. Corporate, no, just NHS. Academic settings, no. Public communication, media, no. Policy, no. So mainly just general practice, and the educational side of things is what's applied to me.
I know that Hussein works very hard in those in some of those other areas. So public communication, policy settings. Anything else you've managed to use your GP with extended role, Hussein? You seem to have your finger in a huge number of pies. So yeah,
Absolutely. I'm looking at the list. I think I've actually probably hit all of them,
yeah,
if I'm being honest. And that's for me, like I've really enjoyed it because working in other spheres, not only just NHS primary care, has built up a certain level of experience and skills that I've utilized back in NHS primary care, working with organizations like Park Run, Swim England, Future Fit, etc. When it comes to training, I work at Red Whale as the lifestyle and obesity medicine lead. And these kind of like skill sets, I think trying to bring in different elements can be super helpful. And ideas that I've, let's say, taken from Swim England, I'll steal and I'll use at Parkrun. And then I suddenly look like this amazing ideas man. But all I'm doing is just moving all the great ideas that are happening in all these different spaces. And more now, when, for example, if I think about the media work, the TV stuff that I do and radio, like there's a real demand for that side of medicine. I think more than ever, people are becoming more health conscious and want to understand what levers can they pull to influence their health. And so lifestyle medicine sits beautifully there. And some of the key reasons why I get invited on to various different TV shows is because of that lifestyle element. They don't just want me to explain and outline the guidelines and what's changing there. They want to give people that are viewing it information around lifestyle medicine. So yeah, for sure. I would definitely encourage people to be brave and maybe try out other areas if there's something they're passionate about. And the key thing is just is learn along the journey. You won't automatically gain these roles just by sort of putting your hand up. But what you need to do is just try to develop training and understanding and experience, and slowly these things will sort of slot into place.
and you've got the enthusiasm to match as well. This is Hussein's fifth talk of today, which is
yeah, it's true.
Is exhausting for anyone, I'm sure. All right, onto qualifications. I think here there's four basic things that you require. You need to be have a medical qualification, a primary medical qualification. You need an RCGP or equivalent route to UK general practice. You need a full GMC registration. And then you need a qualification in lifestyle medicine. That could include multiple courses. And hopefully we will cover a few of them. I know we've already talked about a few. We've talked about, and they're listed here, the core accreditation. Also, there is the International Board of Lifestyle Medicine diploma. So thanks again, Rachel, for getting that right. There's prescribing lifestyle medicine, and then there's the Red Whale course, which is another option. So Sally, you talk a lot about some of the behavior change stuff, and I mentioned we come back and talk about some of the courses that you could possibly do to learn a bit about behavior change and coaching. Have you done any of these? It's as you're reading, I'll
So
there's
I can jump in. I've done a personalized care institute accredited health coach course. That's not just one. They have a number. I can't remember exactly how many. I think there's over 12. But that's what I would recommend. Try and select one that has been PCI accredited, and then you're unlikely to go wrong.
How long did it take, Hussein? How long was that?
Yes, so for healthcare professionals, let's say like GPs, then they encourage you to do the 2-day course because that will help you to implement the skills within your current sphere of work. If you want to start practicing as a health coach specifically, then the 4-day course which is the one that I did. Not that I want to practice as a health coach. It's just that I love learning stuff. So as soon as I did the 2 days, I kind of was like, I'd love to know what they're talking about in the day 3 and 4. But yeah, no, for GPs that just want to utilize it within their work, 2 days. If you do want to specifically work as a health and well-being coach, then it's the 4 days.
Okay. The last one is the Active Conversations course run by the Faculty of Sport and Exercise Medicine in collaboration with Moving Medicine. I've done that. It was a 16-hour course. It was part online, part in person, or in person it was on Zoom. But yeah, it was great. I really enjoyed it. It was kind of enough, but not too much, manageable for a GP trainee when I did it. There was some questions about GP trainees there, or there has been about courses, and we acknowledge the costs a lot, and someone highlighted how much these things can cost. Here are a few kind of free courses you could do. The top two on the last page have been repeated again here. So kind of NHS e-learning, and then All Our Health, which is a kind of there's quite a few different options in there, so that's worth checking out, particularly if you want to get some extra hours of CPD. And BMJ Learning has got an online course for physical activity and the treatment of long-term conditions. And then the Physical Activity Clinical Champions, if you haven't heard of, is a really amazing resource and worth checking out. Sally, have you come across that before? The PAC course or
but not done it.
Yeah, there's lots
I've
of
done
kind
it.
of PAC training.
It's fantastic, and I'd also recommend because they're always looking for more educators of the physical activity clinical sort of champions training course. So if you want to actually be a clinical champion delivering it, that can be another way of working as an extended role. Because great stuff that they sell.
I just briefly fire through these, and then we can answer some questions, hopefully. Online resources and support. Moving Medicine is a really great resource worth checking out. The Chartered Society of Physiotherapists host lots of information, and then as does the Royal Society of Public Health. They've got an allied professionals hub, which can be really helpful. We are the physical activity and lifestyle team at the RCGP, and we highlighted a few physical activity qualifications. So there's the Diploma in Exercise Medicine from the Faculty of Sport and Exercise Medicine. There's a number of MSCs, and there's probably some people in the chat here who've done some MSCs in physical activity for health. There's one at Edinburgh Uni, and then there's SIMPSPA training, which is the Chartered Institute for, Hussein, you're gonna have to help me out here. What does the MFPA stand for? I don't know.
That's
That's okay. It's not just me.
Course as well.
It's not just me. It's the
Chartered Institute.
I've got stage fright. That's all right.
Let me Google it.
And then the other thing we kind of just want to highlight here is the British Society of Lifestyle Medicine is a great network to meet other like-minded people, to share ideas, thoughts, inspirations, and support each other. Because sometimes delivering these things can be a bit lonely if you're the only person in your practice that is got a real passion for it. You sometimes think that or you sometimes need a bit of inspiration, and that's also what we hope to do at the Physical Activity and Lifestyle Group. So sign up to our newsletter, blogs, get some hopefully some helpful updates, and find out about other people doing similar things to you. Here is a QR code to the hub, the Physical Activity Hub toolkit and resources. You'll also find a link in there to the GP with extended role in lifestyle medicine. And then the other QR code on the right is a link to the upcoming, the final 2 masterclass webinars in July and August. Great. Sally, Hussein, is there anything you want to add before we launch into some of these questions?
I would say that what's really important to consider is like how are you going to go about sort of building up that portfolio, because we talked about the training and that's important. That's an important step, and you have some options that we shared there. but also how can you build up experience and a sort of CVs that when you are looking at moving into one of the other areas that we've showed in where you can work, how can you demonstrate your experience and what you can bring to various different projects, either within primary care or not. And just to answer one of the questions that came in terms of funding opportunities to help with your projects within primary care, then yeah, there's lots of places to potentially access that. So over the years, I've accessed quite a large pot of money. The main sources include council grants. Includes the active partnerships. So the active partnerships are in England and Wales specifically, and they will provide in particular physical activity projects with potential funding. And also think about things like sport legacy funding after big events like the Commonwealth Games, etc. And finally, also consider what potential funding you can get from sort of partners in the local area. So, for example, our Everyone Active Gym have supported us with funding to deliver certain sessions with patients, etc. So, yeah, there are plenty of places to go about doing that. But if you have a clear project plan, which is not too long, and it shows kind of what the benefits that you're trying to bring and what kind of requirements you need, then you can go about accessing funding for sure.
Cool. Sally, if there's anything you want to add, I'm going to dovetail it with a question, which I'm not surprised. You're super inspirational, and managing to kind of do a fellowship in lifestyle and run clinics and create booklets. It's really amazing. But Katie has a question about, is there a role that exists where GPs can use their coaching qualifications?
It's a really good question. I saw that, and I have been thinking on that. So the coaching, mine was a diploma, so I think towards 9 months. So when I have eventually handed my essay in and qualified, I will then be a qualified coach, so I can coach in everything. It's not just in health and well-being and lifestyle, but that is primarily what I did it for. And it has changed how I consult with patients. So I have found that really useful, and particularly in the lifestyle medicine clinics. But I am not sure, I'm struggling to think of where we will be able to use that as a
I can jump in if you want from
coach.
kind
Yeah,
of
Hussein, yeah.
So for me, like the whole sort of skills that I learned at the when I completed my coaching qualification, like I utilize it everywhere. So I utilize it one in the consultation room in that it helps stop me from just regurgitating the information that I know about lifestyle medicine, thinking that, oh, I'm so clever, I know all these, evidence-based tools, to understanding that I need to support the patient to generate those ideas and shift that perspective. And then within the group consultations, if you're not careful, you can end up just doing group education. If you just go through various bits and bobs with patients, then you're just educating them on long-term condition. Well, instead, you want to help facilitate discussion, idea generation, and you just start creating an environment. So it's definitely shifted how I practice. I think before I used to think I was doing those things, but in reality, I was just educating, and it's really helped that shift. So definitely, as a clinician, I think it's really useful. It will definitely change your practice and how you go about it.
Thanks, Hussein. There's a couple of comments. Alison Binns shared the Scottish Physical Activity Questionnaire. So thanks for doing that. And Danny Golding also shared some behaviour change courses that are run through UCL, which is great. Kieran, I'm just going to go back a question for back a slide for the QR codes. That's super. Sally, question here about evidence base for things like relaxation techniques that you could share with skeptical patients. Have you, I've kind of put you on the spot there.
Yeah.
Sorry.
Lots and lots of evidence base for lifestyle medicine that I am aware of in terms of all 6 pillars, but for relaxation apps, nothing quite to hand at the moment. That would be something that I would have to look into. Hussein, have you got any evidence base for specific apps?
Yes. So yeah, in sort of the red mail material that we completed, we did look at the evidence behind a number of the kind of relaxation tools that are out there. Sadly, the evidence was relatively lacking in terms of the independent research that's been done on it. So there isn't strong evidence that a number of the commonly used tools provide a huge amount of benefit. So what I tend to do in this space is if patients find personal benefit from using these kind of things, then I will, encourage them to continue, utilizing it if they get personal benefit. But I tend not to signpost to anything specific because I don't have evidence base to support any specific in there.
Question on indemnity, extra indemnity. From my understanding, if it's delivered within your standard primary care role, no. Hussein, I know you've spoken to the MDU about this. Can you add anything extra?
So they have got a which hopefully we'll share around. I'll send it to the team in order to pop in the chat. But they've created a blog going through this. And as Callum rightly said, in simple terms, if you are delivering lifestyle medicine to your own patients or patients within your primary care network or cluster, then you do not need additional indemnity. However, you should inform your indemnity provider of that. If you are delivering it outside, let's say you're working with a local leisure centre or local council and they are employing, then you will probably need to have additional indemnity to cover. But again, this is something to discuss with your indemnity provider. You can run into some challenges with some providers, depending on their experience doing and supporting that. But I'll share this blog with to a bit more detail as to what to look for and what to do. And within that, in the MDU blog, they highlight how actually working and meeting the requirements of this framework can help to demonstrate that you have competency in this area. Because so what they do in any kind of medical legal issue is they need to demonstrate that what advice you were giving, you had the required training and confidence and knowledge in that area to do that. So they specifically highlight that this framework is useful to demonstrate that you meet that competence.
Perfect. Look, I'm aware of time. There's a few questions we haven't answered. One about observership. Pooja, if you want to email one of us, please do. The email for the active practice at rcgp.org.uk. Someone could put that up, use that email, and you can reach Hussein or I. Sally, before I pass over to you with a final word of just some advice on how to pursue a career in lifestyle medicine, just to close, I will just say, if just a very brief bit of advice would be great, but I'll just say the slides will be available. They'll be available on the RCGP YouTube channel. So please, if you missed things, if you want the resources, do reach out, email us, check out these QR codes. And if we have questions, I'm really sorry, but again, either email us or reach out in some other way, and we'll try and answer them for you. That's great, Sally. Just over to you for just a bit of advice on how best to pursue a career in lifestyle medicine.
The time is right for lifestyle medicine at the moment for all the reasons that we've just discussed. So we are absolutely on point. So speak to everyone. Send information out everywhere. I specifically wanted to have data metrics so I can go and show PCNs, ICBs, other areas of funding that a lifestyle approach absolutely does work, and patients have loved it. So I would just really encourage anyone who's interested to do that, and obviously qualifications if you're wanting to practice as a GP in lifestyle medicine.
That's great.
It's almost an antidote to burnout for the last year. So it has been a joy doing lifestyle medicine clinics.
Right. Well, look, thank you so much. Thank you, Sally. Thank you, Hussein. Thanks, everyone, for joining. Please do complete the evaluation if you can, and we'll see you next month.
Have fun.
Guys, bye. Thank you.